Knowledge questions. We start. Let's first go through these MCQs and then we go to the scenarios. Which one of the following sympathomimetics act indirectly? Adrenaline, no adrenaline, ephedrine, and amphetamine. Amphetamine. Thank you so much. So when you look at the notes for the directly acting guys, you'll be able to find these. Actually, even ephedrine, I saw it, but then they said it can as well get to act directly. And then direct effects on the heart are determined largely by alpha 1, alpha 2, beta 1, beta 2 receptors. Beta 1, thank you. Which one of the following agents are beta receptor agonists? Epinephrine, isoproterenol, isoprotere. Oh, you can read that one. And then methoxamine, dobutamine. Oh, I'm going to go back to read. Thank you. Anyone that can help with this one? Which one of these is a beta receptor agonist? Epinephrine. Are we all good with that? So this one is what we skipped. Which one of the following effects is related to the direct beta 1 adrenal receptor stimulation? Beta 1, bronchodilation, vasodilation, tachycardia, bradycardia. Thank you so much, tachycardia. And I want to go back to the previous question so that is there anyone that wants to comment on the previous question? Anything that they feel before we move out? Beta agonist, yes. Pardon? Dobutamine. Okay, thank you so much. Is there anything more before we move? Or okay, what's the difference? Like dobutamine and epinephrine, how are they differing as the way they work? Anyone that wants to say something on that? Yes. Yes, Doc, you can go on. Is there anyone else who wants to say something? Okay. Where is that? The epinephrine, we know it's a direct hormone that is produced from the neurons, right? From the sympathetic neurons. And then we also need to know at least some drugs that for those which are alpha 1, those which are alpha 2, like those which are specific like that. So dobutamine is a beta 1 agonist. And then for epinephrine produced, I don't know the actual mechanism of action, the way it's working. on which specific receptor it's supposed to attach. But dobutamine, yes, attaches, you use it in the heart when someone has got tachycardia, because of the stimulation of beta 1 receptors. So when you give this drug for the tachycardia, it will be able to help because it is a direct beta 1 receptor. Actually, not used in tachycardia because it is going to cause tachycardia. It is an agonist. So when someone has got bradycardia, that's a dobutamine. Which of the following drugs cause bronchodilation without significant cardiac stimulation? Isoprenaline, terbutaline, xylomethazoline, salbutamol. So in other words, which one of these is more going to act on the beta 2 receptors and not the beta 1? Salbutamol. Thank you so much. Selective beta 2 drug. Which physiological response are typically associated with alpha receptor stimulation? Relaxation of GI smooth muscles, contraction of sphincters, stimulation of insulin secretion, stimulation of platelet aggregation. B, contraction of the, yes, that's true. How about A? What's wrong with A? So I realize this one also A is correct. There will be a relaxation of the GIT muscles, but then the sphincters will contract. That's why when I'm running, I don't feel like going to the toilet because there's a relaxation of the smooth muscles in the GIT and then the contraction of the sphincters. Insulin secretion, its inhibition is actually by the alpha 2 guys who inhibit the secretion of insulin. Which of the following drugs is a non selective alpha receptor antagonist? Non selective. Prozicin, phentolamine, metoprolol, phenoxybenzamine. Okay, the first one, prozocin, is a non-selective alpha 1, working on both on alpha 1, alpha 2, and alpha 3. Indication of alpha 1 selective indicate the alpha 1 selective antagonist. Phentolamine, hindolamine, prozocin, labetalol. Okay, let's like Dr. Shitoma with this question anyway, for the sake of sake. Anyone that can answer this one? Phentolamine, thank you so much. Which of the following is the most important therapeutic property of glucocorticoid in clinical practice? Metabolic effect, immunosuppressant, anti-inflammatory. Anti-inflammatory. Okay. Anything else? Are we all good with it? Okay. Which one of the following is the main mechanism in which glucocorticoids act as anti-inflammatory drugs? Block the action of cytokines and chemokines, inhibit phospholipase A2 and prostaglandin synthesis, inhibit the migration and neutral and leukocytosis. B, thank you so much. Inhibit. Let me just show how that step moves because there is actually a nice clinical application as to how we need to know the inhibition. So here we have got, in our cell membranes, we have got cholesterol. So we have got membrane phospholipids. These membrane phospholipids, they can be converted by this enzyme phospholipase A2 into the eicosanoids, isn't it? And then this guy, so we have got phospholipase here. This guy now can go and form prostaglandins using the COX cyclooxygenase, or you can form leukotrienes that is going to be using the lipooxygenates. Now, each one of these guys have got a specific thing that they do that helps. If there is a so if we block this step, it means that we are not forming prostaglandins and we are not forming leukotrienes. Let's start maybe easily with the leukotrienes. Any function of the leukotrienes? Anyone that can help with any function for the leukotrienes? Okay, so the leukotrienes are involved in constricting the bronchioles. Besides that, they also attract neutrophils to the site where they've been released. So you see, because they contract the bronchioles, that's why in asthma we use a leukotriene antagonist and those drugs that stop the synthesis of leukotrienes because there's going to be inhibition of this guy. For example, there's a drug that you are going to see, it starts with Z. Is it zero tone? Something like that. One thing you need to know about this guy is that it's normally avoided because of hepatic problems in case it comes. And then when you come to the prostaglandins, you are going to find different types. PGE2, that is going to be involved in pain, fever. That's what you want to inhibit to be able to treat, right? That's why NSAIDs can be involved in treating fever and pain because they're specifically inhibiting those. And then you have got also those that are going to be involved in vasoconstriction, platelet aggregation. So that's why if you give NSAID, someone will be bleeding, right? Because these guys are involved in platelet aggregation. Okay. Which corticosteroid possesses the highest mineralocorticoid function? Hydrocortisone, prednisolone, fludrocortisone. Anyone with to help with this one? Hydrocortisone. Thank you so much. So someone that lacks a mineralocorticoid, someone that doesn't have cortisol, if you want to treat the condition, you don't just give them cortisol direct. Instead, you're going to give them hydrocortisone. Corticosteroids are useful in the treatment of all the following disorders except Addison's disease, allergic rhinitis, Cushing's syndrome, inflammatory bowel disease. Anyone that wants to help with this one? Inflammatory bowel disease involves two conditions: ulcerative colitis and also, what's the other one? Crohn's disease. So if you look at, these are corticosteroids. You know they are involved in so these guys are involved in those conditions where the immune system is overreactive. So in other words, which one of these conditions here is not caused by an overactivity of the immune system, where the immune system is destroying their own cells? Anyone to help? Cushing's, right? Thank you. This is why you have got overproduction. Is it of cortisol? Addison's, there's a reduction. And then we need to be able to differentiate with Hashimoto's. And then there's also the allergic. This is, you can see inflammation and it's allergic. So obviously the immune system is involved. Inflammatory, that's also the immune system is involved. All of the following adverse effects commonly occur with glucocorticoid therapy except glaucoma, increased risk of infection, hypotension, peripheral edema. Any thought? Glucocorticoid. Basically, we are saying which one of these is going to be caused by cortisol, which is the basic glucocorticoid. You know, cortisol causes the reabsorption of water. There's going to be the reabsorption of salt and those. So, what do we think will be the effect? Or retaining water and some of those sorts. So, when you retain water, you expect that someone is going to have edema, right? And these are glucocorticoids. Again, you are inhibiting the inflammatory, you are inhibiting the cells that are supposed to help you in fighting infections. Think of things like corticosteroids, right? So there's going to be an increased risk of infection. But hypotension, no. Because when you retain water, you're supposed to have hypertension. That's what cortisol does. So this is the direct opposite. It also causes glaucoma. A 27-year-old woman with asthma has been using an inhaler, albuterol, 3 or 4 times every day as her only therapy. I breathe a lot easier after it takes several puffs, she says. She feels well otherwise. Which of the following statements applies to this patient? What treatment plan? A. Her treatment plan is inappropriate and needs to be modified. B. If pulmonary function tests performed today are normal, the diagnosis is likely incorrect. She does not have asthma. C. She is likely to enjoy activities such as cycling and skating, in which she breathes cold, clear air. She is most likely to have trouble and with her breath when in a warm, humid atmosphere. And then she is probably slightly bradycardic and hypertensive from the drug's expected actions on heart and peripheral vasculature. So if she is now started on corticosteroids, which part of the treatment modality does this approach meet? Is it a rescue control, second line, or is not a rational approach? Okay, thank you so much. So corticosteroids, these guys will simply stop the inflammation together with their others which are known as hormones. These guys, they are preventing the condition from happening, meaning that if the condition has already happened, because they are not involved in relaxing the muscles, the smooth muscles that they've constricted, so they will not help at all. Yeah. And then, what is the mechanism of action of the corticosteroid therapy? Anyone to help there? I think we've started these questions for us. What is the mechanism of action of the corticosteroid therapy? Thank you so much. From what the doc has explained, corticosteroids are basically blocking the production of prostaglandins, which we know are involved in constricting the airways, right? Because they're involved in contraction. So that is helping in the treatment, actually. But not really, they are not involved specifically with the muscles. That's how, like when it comes to the relaxation and the problem in this, there are three many problems in asthma. Number one, there is edema, there is mucus, and there is also constriction. These guys don't really work on preventing the constriction. Instead, they are going to be involved in getting to stop the production of those prostaglandins, and that is going to be the one that is going to reduce the production of the inflammatory mediators, If they imagine the inflammatory mediators, let's say the histamines have been released, those are the ones that are going to cause the contraction of the bronchioles. So we are stopping the production of those. So it is a potent anti-inflammatory agent. It is going to make the leukocytes, which are the white blood cells, to undergo programmed cell death, and that is going to stop them from releasing the mediators. Besides that, it also decreases the vascular permeability so that the leukocytes which are in blood won't move to come and release the inflammatory mediators. Name one side effects of steroids. Anyone to help? Any side effect of steroids? Osteoporosis, weakening of the bone because they are stealing calcium from the bone. Thank you so much. Anything else? Any other side effect? So we go just for that. So imagine you have got these, let's say the steroids we're talking, let's say we get the any steroid, and you know what happens when you have gotten a hormone? When the hormone increases, it goes back and inhibits the hypothalamus and the pituitary gland so that not more of it is produced. So there's going to be also separation of the hypothalamic, pituitary, adrenal axis. All right. And the next part of the question, the patient stops taking medication after 3 days. What is the most likely reason for her decision? What could she have been told to prevent this outcome? Anyone that wants to help with this one? Let's analyze from the drug that she's taking, and then she stopped taking the drug. Why did she stop taking the drug, and what could have been done or should have been told her to prevent the outcome that she was told? Anyone that wants to contribute there? Okay, please go on, Doc. Okay, okay, all right. Thank you so much. Is there, before we go on, is there any other thought? Also, maybe she developed tolerance. Thank you so much also for that. Anything else? And let's look at the again the problem. So here our patient is taking these steroids, the corticosteroids. And you know corticosteroids, besides them being used as controllers, they can as well be used for mild cases, right? Mild to severe cases of asthma. And now the patient has been taking this for 3 days. You know, maybe they felt a bit okay, and then they felt it's no longer necessary for them to continue because at that point the leukocytes have been inhibited at that point. So that can be another thing. So maybe you can advise them to continue so that there's not going to be anything that is going to be left in case someone stops taking the drug and then they end up feeling bad another time. So it's necessary that they complete the dose. Okay, and then which other part? What is the likely cause of death in this patient if steroids are not taken? Any thought on that one? Reason what can cause death if they don't take the steroids? Now, someone has got asthma and they don't end up taking the drugs. In asthma, just like epilepsy, there is the condition, the worst case scenario of the condition. Like epilepsy, there is what is known as status epilepticus. Same with asthma, status asthmaticus. That's like the worst scenario where someone will be failing to breathe. So probably they stop taking the drug and then they are not able to breathe because of status asthmaticus, where there is a severe respiratory failure, they can't breathe themselves. So that can take their life because that is a life threatening condition. Is there anything to add, or maybe someone is not good with that? Okay. And then, what is the second line treatment for patients who cannot tolerate beta adrenergic agonists? Anyone with a thought on that one? Thank you so much. Yes, basically that. So if someone can't take the beta agonists, they can take the antimuscarinics because they also dilate the airway. What drug or drug class can be combined with beta agonists that enhance its effectiveness? May be an alternative to steroids in children. How about that one? Any thought? Any thought? So, what we need to know about steroids, sorry, about beta agonists, specifically the long acting, is that you don't give them alone. You are always supposed to give them with corticosteroids. So that's a drug that we can give them with. And then E, what is the mechanism of action? So basically, I think it's a mechanism of action of what we've said in D, that's the, the corticosteroids. Is that not what we are just from mentioning? Or maybe there. So the mechanism of action for corticosteroids we already know. It is reducing inflammation because of preventing the release of inflammatory mediators. For the beta blockers, they prevent the constriction of the airways, they cause the airways to relax. What is the best option for this patient if the trigger for the asthma attack was allergies? Anyone to help with that? What class of asthma drugs do you use in someone that is allergic to something? Thank you so much. The IgE monoclonal antibodies. What is the mechanism of action of the drug or drug class that we've stated? So, what is the mechanism of action of the IgE monoclonal antibodies? Anyone? How do antibodies lead to asthma? So that is a basic question there. Any thought? Thank you so much, Doc, for that one. So here is our antibody IgE, like that. And this guy, for us to have inflammation, is going to bind to mast cells. When it binds to mast cells are going to degranulate to release those inflammatory mediators, the histamines, the leukotrienes, and these other things. So we need an antibody against an antibody. So we need an anti IgE. So something that is against IgE because it's IgE that is causing the release of the mediators. Right. So that is that for that question. Sorry for that. What is the best option for this patient if the trigger for the asthma attack was okay? We've already answered that. And then next, a 35-year-old woman, Jane, presents to the emergency department with a severe asthma exacerbation. Over the past week, she has experienced increasing shortness of breath, wheezing, and chest tightness. She reports that she has been waking up at night due to difficulty breathing and has had to use her inhaler multiple times a day. Jane also mentions that she has been feeling fatigued and has had a persistent cough. Upon examination, Jane is found to be in a respiratory distress with a respiratory rate of 28 breaths per minute, oxygen saturation of 88 on room air, and widespread wheezing on auscultation. A peak expiratory flow rate is 40% of our predicted value. Describe the pathophysiology of asthma and explain how it leads to the symptoms experienced by Jen. That's true. Is there any addition to what the doctor said? Thank you so much. So there are actually three basic things that are involved, as I already said earlier, in asthma. So you have got bronchoconstriction, you have got increased mucus secretion, and then there is also edema, bronchial or edema. So the problem here is that for whatsoever thing that has come, that has entered the respiratory system, there is chronic inflammation in response to any trigger. And because of that, the respiratory system will start now secreting things. So there's going to be hyperstimulation of the respiratory system, and then there's going to be uh, the release of there's going to be constriction. The aim is you are trying to prevent whatsoever was causing the problem. Besides that, there's also mucus being released from the goblet cells, so such. So that's a basic thing. You have stimulated the narrowing of the bronchial walls, the release of mucus. But when you look at the specific thing like what can cause asthma, you can have the intrinsic asthma and the extrinsic. Specifically, the extrinsic is being caused by something from the outside, like an antigen is going to enter the respiratory system, maybe something that you're allergic to or something, and then is going to be able to stimulate mast cells. So mast cells will be sensitized, and then the second entry of that same antigen is going to cause the degradation of the mast cells. But remember what caused this desensitization was because of the IgE, which had bound to the mast cells to be able to sensitize them. And then the mast cells for the second time is going to degranulate, leading to the release of these histamines and other inflammatory mediators that cause constriction of the airways and the prostaglandins actually. And then number B is saying what drug can be administered for the immediate management of Jane's acute asthma exacerbation in the emergency department, and how is it delivered? Anyone to help with that? What drug can we use in the emergency department? Thank you so much. How do we administer it? All right, thank you so much. So for every asthma attack, we're supposed to use the short acting beta 2 agonists. Now, because it's an emergency, you need something to work very quick, right? So for emergency situations, you actually use a nebulizer. So you have got two important ones that you can use a short acting beta 2 agonists. They are butyryl or terbutaline, which you can as well give orally. Terbutaline, you can as well give it subcut. Yeah, but for emergency, a nebulizer is better. What is the mechanism of action and major side effects of the above named drug? So we have said the short acting beta 2 agonist. What is the mechanism of action for these drugs? Anyone? So the basic thing is that these guys are going to cause broncho. Thank you so much. Vasodilation, more blood there. Or the basic thing is that they'll actually cause bronchodilation, isn't it, Doc? Thank you so much. Bronchodilation, that's a basic mechanism. And then, why do you decide to initiate long term? When do you decide to initiate long term therapy for this patient? Anyone that can help with that? So, remember when someone has got whatsoever asthma attack, whether it is mild, moderate, severe, you're supposed to give them short acting beta 2 agonists. But when are you going to decide to start now giving them the long term agonists and other long term medications? Sure. Thank, thank you so much. So, the patient using the short acting drug for more than twice a week is supposed to initiate long term. And then he is saying what drugs should not be used as monotherapy. What other drug class should they be used with? So we've been using the word is supposed to be glucocorticoids. And then what drugs would you have used for prophylaxis which causes no bronchial smooth muscle relaxation? Anyone with a thought on this one? Yeah, the glucocorticoids. There's supposed to be another one. The hormones. Yes, thank you so much. So glucocorticoids and the hormones. And then G is saying you decided to add xylitol, which is a 5-lipoxygenase inhibitor. What are you afraid of as you administer this drug? And what measures do you take? What is the mode of action? What is the mode of administration of this drug? So there are three questions. What are you afraid of? What measure do you take? And what is the mode of administration? Anyone to help with that? Thank you so much. We are afraid of hepatotoxicity. And then what measure do we put in? Thank you so much. So we'll be monitoring the liver enzymes. And then what is the mode of administration of this drug? Oral, right? Thank you. So actually, uh, xylitol is an agonist for, as we talked about the mechanism from the glucosinase, we are going to be able to produce the prostaglandins and the leukotrienes. Specifically, the leukotrienes, we can have drugs that will inhibit the production of leukotrienes. Specifically, xylitol is one. It inhibits the production. We have also drugs where the leukotrienes have already been produced, but we are preventing the attachment of the leukotrienes to the receptors. And those are the drugs like, you are going to see them ending in cast, Zafalucast, Montelucast, like that. And all these drugs administered orally, they actually have the same what? The same effectiveness, both classes, like those which prevent attachment to the receptor and those that prevent the production. They have got the same effectiveness as low doses of glucocorticoids. So the same way the low doses. You notice that when you brought flowers near the patient, the condition worsened. What would be the best treatment in such a case, and how would you administer the treatment? Anyone to help with this one? You, yes, thank you so much. Yes. And then how do we administer the drug? So we are going to use it because he's allergic. This we are going to use the anti-IgE monoclonal antibodies, and these guys are administered subcut. That's a method in which they are given. So subcutaneously. 28. A 20 a 28-year-old man, John, presents to the clinic with a 5-day history of fever, chills, and sweating. He recently returned from a trip to a malaria endemic region in sub-Saharan Africa. John reports that he did not take any malaria prophylaxis during his trip. On examination, he has a temperature of 39 degrees Celsius, a heart rate of 110, and appeared jaundiced, and a positive rapid diagnostic test for Plasmodium falciparum. You put John on medication. Briefly describe the life cycle of Plasmodium falciparum and explain how it leads to the symptoms experienced by John. Anyone that would want to, like, it's brief, not the microbiology aspect, just really brief. The life cycle of Plasmodium falciparum, specifically the human cycle, that would be the most important because that's what is causing the symptoms. So the female Anopheles mosquito bites a human being, and then after that bite, the sporozoites are released. Sporozoites are going to go in blood, and then they go to the liver where they are going to change into seasons. And then these seasons are going to be able to release, when they rupture the hepatocytes, are going to release the merozoites. The merozoites are going to go into blood and then infect the red blood cells. They'll start multiplying and then they'll start rupturing the red blood cells and spreading like that. So as they rupture, they are going to be causing these symptoms like fever and chills that we can see. And because of rupturing the red blood cells, that's how the patient is also going to be anemic, right? And red blood cells, when they're ruptured, you are releasing the hemoglobin, which contains heme, which we can, and also, so that those products from the broken red blood cells are going to be able to cause also jaundice. And then be saying what are the possible causes of anemia of the anemia that John has? Anyone? What are the possible causes? We have already mentioned one. Yes, please. Yes. It has an hepatic stage. It's just that it doesn't stay there. It doesn't form hypnozoids, which can cause relapse, but it goes there in the liver. Right. What is the possible cause of the anemia? Anyone that can help with that? So remember, the question is saying you put John on medication. So possible causes of anemia. The drugs that we use to treat malaria can cause anemia. Things like chloroquine, quinine, and also the parasite itself can cause anemia. So those are the two possible causes: the parasite and the drugs that we are using to treat the condition. So mefloquine, chloroquine, and is it quinine? Those are three causes. Especially there is also glucose 6-phosphate dehydrogenase deficiency. They'll cause anemia. What drugs would you have given John for prophylaxis before traveling to a malaria endemic area? And what are their mechanisms of action? So let's start with the drugs. What drugs do we give for prophylaxis of malaria? Thank you so much. There is the atovaquone proguanil combination. Is this the fancy? Is it the one? Which one is known as fancy? Okay, so That's the first one. Atovaquone and proguanil. What other drug class or drug can we use for prophylaxis? Anyone? Also mefloquine, yes. So that's the second one. And then now the last one. So there's also the doxycycline. So those are three guys. Actually, fancy is those guys which inhibit synthesis of folic acid. So mefloquine and doxycycline. So now we can talk about the mechanism of action, starting with atovaquone and proguanil. How do these guys work? Anyone that can help? Atovaquone, what it's doing is that it's going to collapse the membrane potential of the mitochondria, and it is selective to only the parasite membrane potential. And what proguanil is going to do is that it's going to supporting atovaquone in collapsing the mitochondrial membrane. Besides that, it is as well reducing the resistance that can happen. But the mechanism of action for the proguanil, it is to stop the synthesis of purines and pyrimidines. So you can see you have combined two drugs that are working by two different mechanisms of action. That's why it becomes a very good combination. We are stopping the membrane potential, we are stopping the synthesis of purines and pyrimidines, which we know are necessary to make nucleic acids. And then mefloquine. Anyone that wants to say something about mefloquine? And the only disadvantage in mefloquine is that you don't use it in every place. You only use it in those places which are sensitive to mefloquine. So it is specific. And I think Dr. Shidumaro mentioned that there's only one country, if I'm not mistaken, if it's not this one. So this one, the way it is going to work is that it's going to bind to the hemozoin, which is present in the red blood cells. So there's the intra-erythrocytic hemozoin. That's part of the hemoglobin. That's where it's going to be able to bind. Another thing that we need to know is that mefloquine is specifically to prevent and treat drug-resistant falciparum and vivax, those two. So don't give it for everything. For both prevention and treatment for drug resistant. And when you see that you have got a strain that is resistant to most of the drugs, you can combine mefloquine with artemisinin or artemisinin compounds. That's for multiple drug resistant or falciparum. But you don't give this guy in pregnancy. So if someone gets pregnant, if you give this drug up to 3 months from the time that you give it, you shouldn't become pregnant. And then doxycycline, this guy is a tetracycline, and we know that tetracyclines inhibit the third SA ribosomal subunit. So we'll be preventing the synthesis of proteins. And then C is saying, what drug would you have given John for prophylactic or for prophylaxis before traveling to him? Oh, that's one is what we've done. D, what drug can be given for radical cure and prevention of relapse of P. vivax and P. ovale? What other drug is it given with to eradicate the erythrocytic stage of the parasite and reduce resistance? Anyone to help with this one? There is only one that we specifically give to stop the relapse that that happens because of vivax and ovale. Yes, primaquine. Thank you so much. And then if we want to prevent primaquine from going into resistance, what other drug do we give it with? So we'll give it with chloroquine. Chloroquine is specifically to eradicate the erythrocytic stages of the parasite, those which are in blood causing the destruction of the blood cells. So we are there to destroy those. What drug can you add to mefloquine in the treatment of P. falciparum multi-drug resistant strain? Artemisinin compounds. Thank you so much. Like ate, artemether itself, it's an artemethin compound. And then you notice that a clinical officer gave John a drug that gave him a triad of synchronism, hypoglycemia, and hypotension. What drug was given and how can you stop these effects? Quinine, thank you so much. So quinine, you see this triad synchronism where you have got problems with hearing like tinnitus, and then there's also hypoglycemia and hypotension. So if these are you've noticed that is caused by quinine, how can we stop them? So we'll simply withdraw the drug. Thank you so much. Yes. So that's a basic thing. Just withdraw. And then G is saying what drugs can you use for malarial prophylaxis and treatment of severe cases in pregnancy? So there are two parts. We want to for prophylaxis and treatment of severe cases, but this is supposed to be in pregnancy. So let's start with prophylaxis. What do we use for prophylaxis in pregnancy? Yes, thank you so much. They fancied that, which is a combination of two drugs, pyrimethamine and the sulfadoxine, and then that is for prophylaxis. And then for treatment, all right, thank you so much. Now, specifically, there are some things that we want to avoid when you are treating someone that is pregnant. Most of these that we mentioned are the mefloquine, the chloroquine, you avoid them. Instead, you are going to use quinine, the old guy. Specifically, it's supposed to be IV, so IV quinine is for treatment, right? And then a 45-year-old woman, Sarah, presents to the clinic with complaints of fatigue, weight gain, and cold intolerance over the past few months. She also reports experiencing constipation, dry skin, and hair loss. On examination, Sarah has a slow heart rate and her thyroid gland appears enlarged. Laboratory tests reveal elevated thyroid stimulating hormone levels and low free thyroxine levels, indicating hypothyroidism. What is a drug you would recommend for the treatment of this condition? So basically, hypothyroidism. Anyone that can help? Thank you so much. Levothyroxine. It's actually a very good guy recommended for the treatment of hypothyroidism because it has got a good ratio when it comes to the T3 and T4. And it is actually a synthetic form of T4. So it's good. And there are some other drugs that you can use. But the only problem is that the ratio in which T3 and T4 is a bit different. For example, is what is known as thyroid USP. You've just gotten the animal thyroid gland, and then you defat it, you remove the fat, and then you dry it. And then you have got the thyroid hormone there. But the problem is that in that one, you have got T4, T3, the MIT, and DIT. So you can't tell the dosing that you are giving because there is a variation. So that's why for the thyroid USP, it is not recommended for initial therapy. And for the first question, levothyroxine. And then what is the mechanism of action of the drug named above? So what is the mechanism of action of levothyroxine? One thing we need to know about thyroid hormones is that they are lipid soluble. And every lipid soluble hormone works on intracellular receptors. So that's what levothyroxine also does. It will go and attach to the thyroid, to the receptor that is inside the cell. And then when it attaches, there's going to change and cause the production of specific mRNA. And then that is going to cause the production of specific proteins like the sodium ATPase pump, which are going to be helping now in the the normal metabolism or the removal of the hormone that you specifically want, like the T3 and the T4. When you are transporting these hormones, you need to have transporters. So basically, this drug is going into the cell, changing mRNA expression and causing the specific production of proteins. And those proteins are the ones that are going to be able to help in maintaining the normal thyroid levels. basically by releasing the hormone. What? How are thyroid hormones inactivated? So, so it is the drug is going to go into the intracellular into the cell, and then it will interact with the intracellular receptors. It is going to alter the production the specific mRNA strands to cause the production of specific proteins, which include the sodium ATPase pump. How are thyroid hormones? Yes, please. Yes. Okay, thank you so much. Now, PTU, uh, there's another one actually, PTU, and is it meth something? Those guys are anti-thyroid drugs. So meaning that we want to use them when you have got hyperthyroidism. Yes. So our thyroid hormones inactivated. Anyone that can help with that? So the basic thing is you want to remove iodine from the hormone. So deiodination. That's how they are going to become inactive. And then D is saying what is hypothyroidism in infancy called as hypothyroidism in infants. What do we call it? So deiodination. We are going to remove iodine from the hormone and then it will be inactivated. Actually, when you get T4, you remove one iodine, it will become T3. If you remove iodine, it's inactivated. Hypothyroidism in infants. What is it called? Thank you so much. Creatinism in adults is known as myxedema. So creatinism is basically myxedema in children plus physical and mental retardation. So someone, academically and just physically. What drug can you use in pregnant woman to treat hyperthyroidism? So this is where we can use PTU. So these drugs we call them thiamides. Thioamides. There are two, PTU and methimazole. Methimazole is avoided because it's teratogenic. PTU is better. We can also use iodide and radioactive iodine for hyperthyroidism. But these are the best drugs we can use. The thioamides. A 55-year-old man, David, presents to the clinic with complaints of increased thirst, frequent urination, and unexplained weight loss over the past few months. He also reports feeling fatigued and experiencing blurred vision. David has a family history of diabetes, and his father was diagnosed with type 2 diabetes in his late 50s. On examination, David's body mass BMI is 28. He's fat, right? And his blood pressure is 140 out of 90. Laboratory tests reveal a fasting blood glucose level of 180. Please let's go through diabetes in pathology also. And an HbA1c level 8.5 indicating poorly controlled diabetes. Describe the pathophysiology of type 2 diabetes and explain how it leads to the symptoms experienced by David. Who can help with that? Thank you so much. That's a basic thing. Insulin is being produced, but then the tissues cannot respond to insulin to take up the glucose. So that's insensitivity. And then B is saying, what is the drug of choice and mechanism of action in managing the diabetes described above? Why does the person using this drug risk having anemia? So we can start with the drug of choice, and we know this is diabetes type 2, right? What is a drug of choice in diabetes type 2? Metformin, thank you. If it was type 1, what would be the drug of choice? Insulin, yes. So metformin. So what is the mechanism of action for metformin? It's a biguanide. How does it work? Thank you so much. It works on the AMP kinase. Of importance, again, we need to know is that metformin doesn't cause you know, when you have got glucose in blood, you need to take glucose to the cells, right? But for you to take glucose to the cells, you need insulin. Metformin is going to reduce the glucose that is in blood, but it doesn't cause the production of insulin. The way it does that is that it's going to project this glucose to some other places where it can be needed. For example, in the muscles and in the lip, uh, lipid storehouses, they are depocytes. That's why there's weight gain associated with most of these drugs that we use to treat type 2 diabetes. That's why type 2 diabetes, someone is going to be fat. Type 1, they are normally thin. The only drug that doesn't cause weight gain, these are the sodium glucose transporter inhibitors. So that's how it is going to work. So besides it taking glucose to the adipocytes and the muscles, it is as well going to delay the absorption of glucose from the GIT. Now you know that when you don't have enough glucose, the body produces glucagon to increase glucose in blood. So it will also reduce glucagon. So that is the mechanism of action. And the second part is saying, why does the patient using this drug risk having anemia? Anyone that can help with that? So besides everything that we have said, metformin also stops the absorption of folic acid and vitamin B12. You know, when you don't absorb folic acid and vitamin B12, someone is likely to have megaloblastic anemia. So that's that. And then C is saying, name. So metformin is going to cause a reduction in glucose without stimulation, without the release of insulin by projecting using this AMP kinase, which is involved in regulating glucose in the body. It is going to project insulin to the body pathways needed, like in the adipocytes and also the muscles. Besides that, is going to cause a reduction in the release of glucagon and also the reduction in absorption of glucose in the GIT. All right. Name the drug used in management of diabetes whose biological half-life is longer than elimination half-life. What is their mechanism of action? Now, this drug, biological half-life is you've given a drug. The drug is eliminated from the body, but even after elimination, the drug has still remained working, but the drug has been eliminated. So the biological half-life is longer than the elimination half-life. Which drug is that? Okay, the sulfonylureases. sulfonylureases. These guys, their biological half-life is longer than their elimination half-life. And even from the way sulfonylureases, what these guys do is that they have got receptors which are known as the sulfonylureases receptor 1. And what they do, and these are potassium lecture receptors. They are like this. This is a potassium channel, and this channel is actually in association with the calcium channel. So what happens that to this receptor, when the sulfonylurease comes and binds to it, is going to cause the entry, actually not entry, but the removal of potassium from the cell. When positive charge leaves the cell, you are supposed to replace another positive charge. So calcium is going to be entering. And you know, when calcium enters the cell, what that is going to do is that is going to cause the exocytosis of not neurotransmitter of the hormone. So the hormone is going to be removed from the cell. When the hormone is removed by exocytosis, that specific hormone is actually insulin. Is going to go and be able to bind to the receptors and then it to be able to cause the uptake of glucose. It is this same mechanism that another class of drug which is known as a meglitinides work by the same mechanism, also binding to the sulfonylurea receptor 1 meglitinides. Drugs like repaglinide, nateglinide. So when you just see those drugs that end in glinide, they also work the same using the same receptor. They they are transport inhibitors, the transport of glucose into the cell. Yes, thank you so much. So the sodium glucose transport protein 2 inhibitors, they are going to stop, they are not involved in hypoglycemia. So actually the way these guys do is that you know in the kidney you have got, let's make it easy and simple. Here is our glomerulus. Glucose and amino acids and just like everything else is going to be filtered here, and nearly everything is going to be reabsorbed. But then we are going to come and inhibit this transporter here. This transporter takes out sodium and glucose from the the tubules, the kidney tubules into blood. So we are inhibiting these guys. So when you inhibit them, it means that we are going to be losing urine in blood. We are going to be using glucose in urine. So you are going to see because of that, you expect the urine, of course, to have what's the condition? The urine has got more of the glucose, and just from the mechanism of action, you also expect the side effects. Someone is going to have polyuria because they are excreting more of this urine. And just think of it, when the urine is more in the urinary tubules, that is giving more chance for infectious agents to be able to grow in the urinary tract. So the adverse effects for this is that someone can have UTIs. Hypoglycemia though is very rare. And because we are losing a lot of this sugar, there's also going to be increased hematocrit because remember we are losing a lot of fluid. When you lose fluid, you are going to remain with more blood cells. So blood cells, because they are high, that increases hematocrit. So those are the adverse effects. Increased urine output, hematocrit is high, UTIs, but less hypoglycemia. He is saying, what is the mechanism of action of acarbose? It is an alpha glycosidase inhibitor. Anyone that can help with that? All right, thank you so much. That's the best mechanism. And the way they're going to inhibit, to be specific, the way they're inhibiting absorption is that when you have got a big chunk of carbohydrate, glucose, carbohydrates are only absorbed as monosaccharides. So anything that is not monosaccharide will not be absorbed. Things like maltose, lactose. So these things will still remain in the GIT. And so what happens is that you are failing to break them down to the monosaccharides. And since you are failing to break them down to the monosaccharides, what happens? You can't absorb them. So you are going to remove them. Now, that can actually also help us to tell the side effects for acarbose or other alpha glycosidase inhibitors. Imagine it is lactose that you are preventing absorption. This guy is going to start causing water to go into the lumen of the GIT. So that is going to cause things like flatulence, bloating, abdominal discomfort, diarrhea, because these guys attract water, they are sugars. So we can tell the adverse effects. And then what drug works by inhibiting DPP4? Is it dipeptidyl peptidase 4? Which drugs work by inhibiting this guy? The incretins, thank you so much. So incretins, these are drugs that work by reducing, because of course they are all reducing glucose anyway. So the incretins. What drug works by activating PPAR gamma? So that's same name. So Dr. Chidimao said you can just write TZDs, because for me I can't pronounce that word. I'll not pronounce it. I can show myself. So the TZDs will inhibit this enzyme. Not enzyme, but this should be a receptor. When they inhibit this guy, what they'll be doing is that glucose now is going to be projected to other mechanisms. Like glucose is going to go into other things. For example, you are going to have uh, your glucose, which is being taken to the muscles, the adipose tissue, and then you're also going to reduce the production of glucose. That's how the TZDs work. It's reduction in the production of glucose. And then there's also, for those cells where there is resistance to insulin, when TZDs bind to their receptors, they're going to reduce the resistance of insulin. These drugs, you are just going to see them. They end in glitazone, like rosiglitazone, pioglitazone. Okay, so that is that. And then the next question. A 60-year-old woman. Oh, sorry for that. A 60-year-old woman with a past medical history of rheumatoid arthritis and chronic iron deficiency anemia is found to have blood in her stool. Colonoscopy is negative, but a gastric ulceration is discovered upon upper endoscopy. You look in the GIT, you find that is an ulcer. After successive treatment of the ulcer, what medication could be added to the patient regimen to prevent the repeated ulcer? One thing we need to remember, rheumatoid arthritis, this is an inflammatory condition. And for inflammatory conditions, what drugs do we use? Thank you so much. NSAIDs. And from our knowledge of NSAIDs, one big adverse effect that they have on the GIT is that they cause ulcers, like peptic ulcers. Uh, Let me ask this one. Between the gastric ulcers and the duodenal ulcers, which one is associated with blood group A and which one is associated with blood group O? Or we can check it up. Okay, so NSAIDs cause ulcers. And that is what we have here. But the problem is that someone has got rheumatoid arthritis. We can't stop NSAIDs because they are the best guys in this condition. But someone is developing ulcers. So what medication could be added on top to be able to prevent the ulcer? or the gastric perforation. Anyone that can help? Methotrexate. All right. By what mechanism is it going to work to help in this condition? Maybe if we can understand that. But others are still free to contribute what they feel. Prostaglandin analogs. Thank you so much. I also had something else. The doc didn't complete. Is there anyone that wanted to say something again? Okay, misoprosto. Thank you so much. So here, misoprosto is going to be a good guy. It's actually a prostaglandin analog, and prostaglandin is actually good for NSAID induced peptic ulcer. And the way these guys work is number one, they are going to be stopping the production of acid. Number two, they produce bicarbonate and mucus, which is more like going to shield the GIT from the acid that is already there. So we get to add them. Okay. What three mediators can stimulate acid secretion from parietal cells? Anyone that can help? What causes the product? What mediators or hormones can cause the production of NSAIDs? Oh, the production of hydrochloric acid from the parietal cells. Thank you so much. Histamine binding to its H2 receptors, acetylcholine also, and gastrin. Specifically, gastrin. Look, let's do it way easy. So here we have got a simple diagram of the stomach. Somewhere on the pylorus we have got gastric cells, and then somewhere body and the top fundus, that's where we have got parietal cells. So what happens that when food has reached the stomach, that's actually a stimulus for G cells to produce gastrin. Gastrin will go and attach there to cause H cell production. Now, specifically, there is what is known as Zollinger-Ellison syndrome. The G cells, the gastric glands, are producing too much gastrin. So there's overproduction of hydrochloric acid. That's in Ellison or Zollinger syndrome. Right. Name three causes of peptic ulcer diseases or disease. The H. pylori, thank you so much. That's one. Thank you. Yes. So prolonged NSAIDs use and also stress, right? Stress, basically any factor that is causing the production of acid can cause peptic ulcers. For example, stress because of an exam that's coming. What type of patients do acute peptic ulcers occur in? Thank you so much. Patients who are admitted in ICU, right? Would there be a reason why? It's because of stress. Imagine you're in intensive care unit, you don't know what is going to happen, right? What is the name of the syndrome that is characterized by hypersecretion of gastric acid secondary to gastrin secreting tumor? Zollinger Ellison syndrome. Thank you. What are the drug therapy goals in treating peptic ulcer disease? What are the goals? Why are we trying to treat peptic ulcers? For most of the conditions that has to do with the central nervous system, is just to reduce the thing. But when it comes to treating peptic ulcers, what are the goals? Thank you so much. We want to eliminate, basically, we are dealing with the causes. We want to eradicate the bacteria that is causing the H. pylori. And we also want to deal with symptoms like there is pain. Someone has got ulcer, so we want also to be able to manage the symptoms and also to prevent further complications that can arise because of the ulcer. Thank you so much. So those are the things. And then, what type of medication are useful for treatment of peptic ulcer disease? We can give maybe the classes. What drugs can we use for treatment of peptic ulcers? We, the triple therapy assessment. Thank you so much. There's another doc that wants to say something. The antacids, all right. Thank you so much. Anything more? Yes, those guys, right? So we can simply put them like this. We have got those drugs that are going to be used to reduce the production of the acid, like the histamine, the antihistamines, cimetidine, ranitidine, famotidine, roxatidine. Of all these, which one is the most potent? Okay, like the protein pump inhibitors are the best, yes. And on the class for antihistamines, of these four that are listed here, which one is the most potent protein pump antihistamine? Ranitidine. Anyone else? What do we say? Okay, something that we can just get to check out. But famotidine is a good drug actually. It's a good guy. And then protein pump inhibitors which end in prazo, omeprazole, lansoprazole, and cholinergics. You know that acetylcholine. This is parasympathetic. Rest and digest. You can't digest without acid. Perizepine, propanthenol, oxyphenonium, and prostaglandin analogs, misoprostol. This guy is working by which one? That is PGE1. That should be the one. And then neutralizing of gastric acid that is already been produced. You can also use antacids. You have those which are systemic. They'll go throughout the entire body, and those which are non-systemic, like the sodium bicarbonate, sodium citrate, those are systemic. Non-systemic magnesium hydroxide, magnesium trisilicate, aluminium hydroxide gel, magaldrate, calcium carbonate. And then you also have those that are going to just this is a mucosa of the jet. You have got an ulcer somewhere, but these are just there like to protect the mucosa from the acid. So these includes like the sulfur, but the most common is the bismuth. Yeah. And then you also have those which will be now fighting the bacteria that is causing the infection. You have got the penicillin, amoxicillin, you have got the macrolide, clarithromycin, metronidazole, tinidazole. These are known as what? Benzimidazoles. And then you have got tetracyclines, Is it benzimidazoles or imidazoles? Because some of those are antiomides. And then you also have the tetracycline, which is a tetracycline actually. How might H. pylori play a role in peptic ulcer development? Anyone that can help? How does H. pylori cause peptic ulcers? Thank you so much. So it can directly damage the mucosa. It can actually also get to cause an inflammatory response that can as well lead to this damage. It can also cause production of gastrin, and gastrin will cause the production of acid. What treatment options are available to eradicate? Now we want to eradicate, we want to do away with H. pylori. How can we do that? What treatment options can we use to eradicate H. pylori? So there is the triple therapy and the quadruple therapy. The triple therapy, what you just want to do is use a proton pump inhibitor and two antibiotics. One, you are always using a macrolide, specifically clarithromycin, and you can use any other antibiotic. Specifically, there is a change that happens between metronidazole, amoxicillin, or tetracycline. And then for the quadruple therapy, you want to either use a proton pump. You basically get a triple therapy plus bismuth, which is a protective, right? The mucosal protective agent. So you can use proton pump inhibitor or antihistamine, any one of those with metronidazole, bismuth, and tetracycline. Why should you not give bismuth subsalicylate to children? Anyone to help with this one? Why don't we give bismuth to children? So you can see, because it contains the salicylate, the same guy that aspirin also contains, it can cause Reyes syndrome. So that's why we don't want to use that. We know that that's what is associated with aspirin in children. What is Reyes syndrome? It is encephalopathy, early onset, fatty liver formation, someone is lethargic, confusion, and those. That's just a definition. Let's go to that. This is a pharmacology. How do prostaglandins help treat peptic ulcer disease? Anyone? Prostaglandins? I can't really get you, doc. Anyone? Okay. So we've been mentioning it, right? Prostaglandins are going to help inhibit the production of gastric acid. They are as well going to stimulate secretion of bicarbonate and mucus, which will protect the cell. And then they also used for NSAID induced peptic ulcer. You know, misoprostol is the best guy for NSAID induced peptic ulcer. Which prostaglandin analog is commonly used as a cytoprotective? We've already mentioned that. Misoprostol. Please take notice, PGE1. One. Why should misoprostol not be given to preterm pregnant women? It can induce premature labor. Thank you so much. Remember, it is a prostaglandin analog, and prostaglandins cause muscle contraction. Okay. A 48-year-old man presents for evaluation of heartburn. He reports a burning feeling in his chest after eating. It is worse when he eats a spicy food or tomato sauce. He is sometimes awakened at night. These with these symptoms. He has tried over the counter antacids and histamine blockers with partial relief. He is on no regular medications. His examination today is normal. An upper GIT X-ray series reveals gastroesophageal reflux along with appropriate diet and lifestyle modification. What recommendations along with appropriate diet and lifestyle modification recommendations, you prescribe omeprazole. What is the mechanism of action of omeprazole? Anyone? Guys, the mechanism of action of omeprazole. All right, thank you. It's a proton pump inhibitor, so it will stop the production of acid. And then, what is the mechanism of action of antacid medications? Anyone? Mechanism of action for antacids? Thank you so much. Neutralization directly. Okay. And then what is the mechanism of action of histamine receptor antagonists? We know they competitive inhibit. Mechanism of action of omeprazole already stated. Okay. An obese 55-year-old man presents to his general practitioner with a history of retrosternal burning discomfort, which tends to occur at night and occasionally wakes him up. The general practitioner makes a preliminary diagnosis of reflux disease. What treatment or therapeutic strategies are available? So, in other words, how can we manage someone that has got the reflux disease? Anyone that can help with that? It's not too far from the way we are dealing with someone that has got peptic ulcers. All right. So remember, the problem is that when someone has got peptic ulcers, the acid can start going back in the esophagus. Specifically, if the patient has got the lower esophageal sphincter is weak, acid will be going up, and then that is going to cause a change in epithelium, right? So you basically give the same drugs that you use to reduce the production of acids. Now, for this condition, like the when acid is going up, what are we calling it? The reflux disease, gastroesophageal reflux disease. It has got stages. Stage one, it is sporadic, it just happens. It's uncomplicated. And the episodes are like 2 to 3 per week. They are not a lot. There is no chief complaint. So you just ask them for stage one to just change, like the modification, lifestyle modification, change diet, right? Like that. You can as well give them some antacids to just get neutralized acid that's already there, or antihistamines. For stage two, it becomes a bit bad where they have got more than three episodes in a week. So proton pump inhibitors will be better. For stage 3, you can give them proton pump inhibitors because it is a bit more bad. The esophagus would have already started also changing epithelium with a Barrett metaplasia, changing from the straight 5 squamous to the column. An 86-year-old woman with a history of chronic constipation is treated with lactulose with good relief of her constipation. She complains of painful abdominal cramps and embarrassing flatulence, flatus, and wishes to try another medication. Look at this, chronic constipation with lactulose. She complains of painful abdominal cramps and embarrassing flatulence and wishes to try another medication. What laxative has a similar medication mechanism of action to lactulose and will not cause large electrolyte imbalance, making it safe to use in this elderly patient? Anyone that can help? A drug that you can use in constipation, but then it will not cause these cramps, these flatulence, and it's better for the elderly patient. But the same mechanism of action like lactulose. Thank you so much. So the polyene glycol, PEG. So it's also an osmotic laxative used in high concentration, effective in lower concentrations for chronic constipation. Concentrations. It is not metabolized by the bacteria that is in the large intestines. So it will be able to decrease the production of gas because as you break down the drug, you're producing gas, and that's what is causing this flatus. And it does not cause large fluid or electrolyte shift moving from the cells into the GIT. So unlike magnesium citrate, sodium phosphate, magnesium hydroxide, it is has less risk of electrolyte disturbance. Okay. So because there's no electrolyte disbalance, is going to be good for the elderly or those that have got renal insufficiency. A 67-year-old woman is receiving chemotherapy for metastatic ovarian cancer. She is on her fourth cycle of multi-drug regimen, including cisplatin and doxorubicin. She has developed nausea and vomiting, among other side effects. You decide to pre-medicate her with IV ondansetron prior to her next dose of chemotherapy and provide oral ondansetron for home use as well. What is the mechanism of action of ondansetron? Anyone to help with that? Okay, thank you so much. So the serotonin, remember this guy is the one that we use in motion sickness also, an antagonist on the serotonin receptor, specifically 5-HT3, not even HT3. This is wrong. TH3 receptor antagonist. So because it is an antagonist, you can see it is both in the GIT and in the central nervous system. It is going to help in motion sickness. And you know, motion sickness, there's a problem. This balance is what is known as the chemoreceptor trigger zone. When it is triggered, there's information that is going to go to the vomiting center to stimulate vomiting. So this drug, you can see we are able to use it in many things. It's acting in the central nervous system and also in the GIT. That's why I can use it. Common side effects: headache, diarrhea, dizziness, agitation. Where am I? Okay. And then during colonoscopy on an 80-year-old Filipino woman, a live worm is encountered. Gastroenterologist asks how long the patient has been in the United States. Why is a physician interested in this information in relation to this discovery? Anyone that can help with this? Someone has got a worm, and then you're asking how long they've been in the United States. Why? So, specifically, there are some worms that are common in the United States. So, if someone has been in the United States for long and then you see that they have got a worm, more likely what they have is cystosomiasis. So, even the treatment is going to depend. Because cystomiasis, the drug of choice is going to be Plasquanto. So that is going to be the most effective, right? No, no. So this cystomiasis actually it's not prevalent in the United States. It's supposed to be less in the United States, but it is more somewhere else because the United States have managed to manage the worm. But everywhere else, specifically this being a Filipino woman, it is much in that locality. So Plasquanto would be the best medication. If the patient has been in the United States for a while, infection with helminth is less unlikely. And so even when you give this Plasquanto, it's less likely to help because the infection is less likely. Maybe it is another kind of one. 24-year-old medical student participates in an exchange. He consumes food dispensed by street vendors and developed a bout of diarrhea. His symptoms subsided and he recovered in a few days. About a month after his return, the traveler developed persistent severe pain in the right upper quadrant of his abdomen. CT scan showed abscess in the liver and hematoagglutination titer of 1 to 2000 for intermeba histolytica. What protozoa drug should be given someone that has got intermeba histolytica? Metronidazole, thank you. Okay. And then a 16-year-old female with dysmenorrhagia is prescribed diclofenac. Question, I forgot to arrange the question properly. So want the mechanism of action of diclofenac and also the effect. Now we know diclofenac is an NSAID, right? And this guy is an inhibitor of cyclooxygenase. It's like aspirin, just that aspirin is permanent inhibitor. When it attaches, it has attached for good. So this guy is also non-selective. You can see it can inhibit COX-1 and COX-2. And when you inhibit these guys, and you know the difference with COX-1 and COX-2 is COX-1 is actually a good COX because it's going to be involved in the protection of the GIT. COX-2 is a bad guy. It's the one that causes injury to the GIT. So drugs that are good, especially in the management of peptic ulcer, should be COX-2 inhibitors. Otherwise, those which inhibit everything are not too good. And that's how diclofenac works. And you know what analgesics, NSAIDs do? Anti-inflammatory, analgesic, and antipyretic, reducing heat, used in pain, cold, inflammation. A 24-year-old woman has continued postpartum hemorrhage despite ergot alkaloids. I don't know how to ask this question. Okay, we can go here. An 18-year-old med-4 student has coughed for 2 days with no fever but a slight headache whenever he coughs. He buys an OTC cough mixture to suppress the cough and allow him to sleep at night. Why do we cough? Anyone that can help with that? So we know it's a body's natural way of getting to protect us, right? In case there's anything that has invaded the respiratory system. And what side effects can be expected with most causes are present. So those guys that are stopping a cough, just like most of the drugs, drowsiness, dizziness, nausea, vomiting, constipation, headache, those are big. And then there's this good guy, dextromethorphan. It's actually a very good guy for cough. It can cause hallucinations and confusions. What is the most effective medication to suppress cough? Anyone that can help with that? So when you're talking about cough, the first thing we need to understand, we have got mucolytics and pectori and the other word. So mucolytics, even from the word muco, that's mucus, right? Muco is mucus. Lytic is to break. These guys are there just to more like break mucus, to loosen the mucus. And we have got one good guy there, acetylcysteine, which is going to decrease hypersecretion, and then it will make the pulmonary secretion to be liquefied, become more liquid in nature. So those are mucolytics. And you don't want to take these mucolytics in someone that has got asthma or a history where there is bronchospasms. And then another thing about these guys, mm, I think that's a basic thing. And then I've got expectorants. Expectorants, these are drugs that are going to increase the volume and decrease the viscosity of bronchial secretions. Like you want to secrete a lot, but then decrease the viscosity. Viscosity is, think of water and oil. Oil is more thick, it's viscous. Water isn't. So the reason as to why you want your secretions to more volume but less viscous is because they can be easily cleared by the cilia on the mucous membrane. And you have got one guy, it's known as guinafenicin. It's the only agent that is approved to act as an expectorant. Should I write that? Guinafenicin. It's written like this. Hope my spelling is correct there. Okay. But this drug, you are trying to help someone to remove the what they have, but it's not good for patients that have got obstructive lung diseases, like the respiratory system is blocked, because how are you going to remove what you're trying to remove if the respiratory system is blocked? So it's actually just better you take more fluids. A- Adequate fluids will actually make or lighten up the secretions from the respiratory system. Okay. And then we can look at now briefly on those drugs that we are going to use in cough suppression, antitussives. And for antitussives, what is happening here is that cough it's all starting from the brain. And when you are talking about drugs that inhibit cough, you have got two classes of drugs. You have got the opiates and the non-opiates. So the opiate agonists like the dextromethorphan and hydrocodone, these are very much potent, and they are going to directly suppress the cough reflex that is coming from the cough center in the medulla. That's how they are going to be able to work. And so the drug classes for these drugs we use for cough, we can classify them as narcotics and non-narcotics. Narcotics, this is codeine. Remember when we are talking about opioids, we mentioned this. Codeine is used for cough. So codeine and hydrocortisone. And then the non-narcotics, that's when we have got the dextromethorphan. So hydrocodone is a cough suppressant. It works more on suppressing cough compared to codeine. But the problem is that it has sedation. It will sedate the patient that is using it. So that's why codeine would be better than it, right? So that's the basic thing that I wanted to mention there. So hope we've gotten that. What is the most effective medication to suppress cough? So dextromethorphan is one of the most effective. As I've mentioned, uh, we have got the narcotics, the codeine and hydrocodone. Those guys are good. The non-narcotic system dextromethorphan. The reason as to why it is better than the narcotics one is because it doesn't affect the respiratory system. You know, analgesics, they can depress the respiratory center, and then it doesn't cause dependence, and then it is less sided when it comes to side effects. So that's why it ends up being a better option than both codeine and the hydrocortisone. What oral gel capsule is used for cough suppression? So we can see this guy, benzonatate. The mode of action, numbing the throat and lungs, making the cough reflex less active. What is a mucolytic? We already defined that it is something that is going to be able to thin the mucus, and that is going to help in clearing the mucus from the respiratory system. It's used to treat respiratory conditions where I've got thick mucus. We also already said what an expectorant is, something that is going to, uh, this one specifically we said is going to increase the secretion in the respiratory system. It's increasing secretions, but at the same time, we are preventing, we are decreasing the viscosity of those secretions so that we can help to remove them. And these are the questions that were in this Kama 1. We are still making up some questions from the high yield topics and also gathering information from trusted sources. So let's keep in touch and let's keep revising. Thank you so much.